I don't know why it's saying that all of a sudden. It never used to say that. Okay. So we actually don't have a lot of material tonight. I think there's two PowerPoints that we're going to go over. Client's response to illness, and then psychosocial integrity, the assessment part. But it's not a lot. So I think that we will probably finish up a little early and you guys can have more time to study. So client's response to illness. So we always know that there are a variety of different factors that are going to influence whether our patients respond to treatment and how successful they are with managing their mental illness. So we need to always understand, first and foremost, that every patient that we see is individual. They all have different needs. They all have different problems, different thought processes. So every patient that we see, we always have to tailor their treatment plan to the uniqueness of each person. We want to implement nursing care that is very personable to each of your patients. We also know that age and growth and development, like every other physical illness that we've seen, will have a huge impact on your patient's ability to cope. And it's the same thing with mental illness. So when people are younger, when they start to develop mental illnesses earlier in childhood, studies show that they are linked to having poorer outcomes. They see more negative signs such as social isolation, a lack of volition, apathy, and then they have less effective management skills. So the younger they are, the poorer the outcome they have. If they develop a mental illness later in life, the prognosis and the outcome of being able to manage that successfully is a little bit better. Also, due to a lack of experience of successful independent living and opportunities to work and be self-sufficient, they believe that that has a huge role on it. So you know yourself, if you live on your own, you can be self-sufficient. You've learned different coping mechanisms. Young children don't have those coping skills. So that's one of the reasons why they believe that it contributed to the poorer outcomes. Expression of illness, so younger age obviously can contribute to an inability or a difficulty to express feelings and understand situations. So, younger children don't always know the full extent of everything. They don't know how to explain things. So it can be hard to really diagnose them and figure out what's going on. So we have to be aware of what language they speak, what educational level they have, and how we can communicate with them so that they can understand us, and then that we can also understand their experience. So for instance, some children that are going through trauma therapy when they're littler, they can't always get it from inside and speak it out. So they will do a lot of where they sit and they color and they do one-on-one and they draw pictures. So that's a good example of how we could work on their level to try and get information from them. And then for us as providers too, doing the same thing, drawing things out for them. According to Erickson's state of psychosocial development, he believed that development is going to occur across the lifespan in terms of those developmental tasks. And he believes that there are different tasks that need to be accomplished at each stage. Each stage is dependent on successful completion of the previous one. So if you do not complete each state, then you can get stuck at a certain point in development. So the example that your book gives, which is a great example, if we look at the infancy stage, from birth to 18th month, they also call that the trust versus mistrust. So if basic needs are not met, like an infant being fed, an infant being bathed and changed and held when they're crying, if we don't meet those needs for those children at that time, then they say that that child will grow up unable to love and trust as an adult. So those are Erickson's theories. And you can read in your book. So the stages of development are on page 117, and the adult growth and developmental tasks is also on page 117. You guys can read that. Genetics and biologic factors, we always know that they also have a big effect on our patients. So genetic makeup tremendously influences a person's response to illness and then also perhaps to their treatment. So we know that some patients don't have any voluntary control depending on their mental illness over why they make the decisions that they make. That's the kind of gray area with mental health. There are a lot of different factors that are not able to be changed and a lot of different factors that play into the patient seeking treatment and being able to recognize that they even have an issue. We know that some mental illnesses do have that genetic and that family history. So when we are doing our nurses assessment, those are essential parts of our assessment. So we need to make sure that we are, if we can get that information from our patients, we want to know, what did their parents have to deal with if they're still alive, or their grandparents? Do they have sisters and brothers? And if so, do they suffer from mental health illness? Those are really important parts of your assessment. So then physical health, health practices go hand in hand with mental health. The healthier a person is, the better he or she will be able to cope with stress or illness. Poor nutritional statuses, not getting enough sleep at night, having chronic illnesses are going to be able to wear a patient down, and it's going to impact their ability to be able to cope with whatever they're dealing with. I think all of you have heard this at some point in time, that exercise is a self-help intervention, and it helps take away the negative effects of depression and anxiety. And that it makes people feel good and healthy, and it's good for your mental outcome. People that exercise, they exhibit a positive indicator of improved health, and a lack of exercise can indicate declining mental health. So a lot of patients that we see that suffer with mental health issues, studies say that a lot of those patients don't have good physical health practices. Not all and every single person, but there is a link. And then we have to think about the response to drugs. So we know, just like with physical illnesses, we give medications and they're not always successful. Well, the same is true of mental health. There are differences in ethnic groups related to metabolisms and the efficiency of the psychotic medications that we give. In patients that have slower metabolisms, we know that serum drug level is going to stay higher in their blood for a longer period of time. So this means that they will require lower doses. But it also means that it increases the frequency and the severity of the side effects because they're taking it more often. So nurses must be alert for the toxicity of certain medications in different ethnic groups that have slower metabolisms. There are individual factors that we look at that determines a person's ability to handle their mental health. So self-efficacy, this is a belief that personal abilities and efforts affect the events in one's life. So people that have high self-efficiencies set personal goals. They are motivated, they are able to cope effectively with stress, and they only request help from other people when it's needed. They're very self-sufficient. People with low self-efficiency are known to have low aspirations. They don't have a lot of goals. They're not goal-oriented. They're not organized. They don't have a lot of self-confidence that they're going to be able to do things successfully. And they also they have a lot of anxiety and depression. Then we say hardiness, which is the ability to resist illness when under stress. So patterns of attitudes and actions that help a person turn a stressful circumstance into opportunities for growth. So some people can work well under stress, and some people can look and say, there's going to be light at the end of the tunnel. This is only for a small, short time. I know that with time, things are going to get better. Not everyone is able to do that. So they say that in order for a person to have hardiness, that they have to have these three components, which is commitment, control, and challenge. So commitment is active involvement in life activities. So life activities, so going to work every day, maybe being enrolled in an exercise program, extracurricular activities. They have a good network of friends and family that they're actively involved in. And then control. So they have the ability to make appropriate decisions in life activities. So they recognize that there's a balance between spending time with your friends and playing soccer once a week and then going to work 5 days a week versus quitting your job to go play soccer 5 days a week. So they know that they have to have control in their life. And then challenge, which is the ability to perceive change as beneficial rather than stressful. So although change can be very stressful and very scary, sometimes it's a good thing. We know that no growth ever comes from a comfort zone, but some people don't see it that way. And it increases their stress, it increases their anxiety. And if they don't have any coping skills, then it just manifests from there. Resilience and resourcefulness also help people cope with stress and help minimize the effects of illness. Which helps to explain why one person will react to a slightly stressful event with severe anxiety, while another person does not experience any distress, even when confronting a major disruption. So if I use myself as an example, when I'm at work, no matter how bad the shift is or what I'm dealing with, I know that I can do it because I can get through anything for 12 hours. That is my motto. No 2 days are the same. Even if I work again tomorrow, it's not going to be the same. I can do it and just get through it. Where some other nurses that I work with, sometimes they will literally just break down in the middle of the day and start crying. And that's okay too. That's just how they handle things. But you need to have resiliency and you need to be resourceful. So resilience is having healthy responses to stressful circumstances or risky situations. So high resilience is going to be associated with promoting and protecting your mental health, which is described as flourishing. Family resilience refers to the successful coping of family members under stress. So if you know that you're dealing, you're in nursing school. Nursing school is very stressful, but you also value your mental health. You are able to implement things that will preserve your mental health. You have resilience. So you can deal with certain things, but you can make light of it and you can see that there's going to be light at the end of the tunnel and you're able to get through it. You need to have a positive outlook. These people usually have some type of spirituality. They have a close relationship with their friends or their family. They have good communication with them and great support networks. And then you have to have resourcefulness, which is using problem-solving abilities and believing that one can cope with adverse or novel situations. We're not just born with resourcefulness. We develop resourcefulness through the interactions that we have with other people, being able to successfully cope with life experiences. Not everybody has resourcefulness because they haven't been able to cope successfully with some big life experiences. So being resourceful is a lot of work for some people. So that's an important thing to keep in mind when we are dealing with mental illness. We know that spirituality is going to help. It involves the essence of a person's being and his or her beliefs about the meaning of life and the purpose for living. We know it can be a source of comfort in stressful times or in times of trauma or when your loved one or you're dealing with a bad mental physical illness or a mental health illness. Hope and faith have been identified as critical factors in psychiatric and physical rehabilitation. People need to believe in something. It keeps them going. Clients with more hope experience fewer symptoms, according to different studies. And guides believe about the meaning of life. It helps them to determine, about the meaning of life, like what they were put on earth for and why things are happening to them. So spirituality is important and we want to encourage it. There are interpersonal factors. So sense of belonging. So people need to feel a sense of connectedness or an involvement in some type of a social system or an environment in which a person feels like they matter. They're an important part of that situation. So it can just be a group of friends. Maybe it's their fellow employees at work, or it's their loved ones. People need to be able to know that they fit in somewhere and that they can depend on that network. Maslow describes as a basic human psychosocial need, that it's going to involve value, which refers to being needed and accepted. So your social network, whether it's your family, your friends, or your employees, your employer, the employees that you work with, they make you feel needed. They make you feel accepted. You feel like you're valued. And then fit, which refers to feeling that one meshes or fits in with system or environment. Same thing. You mesh in well with your friends and your family. It just feels right. When a person belongs to a system or a group, he or she feels valued and worthwhile within that support system. They have a sense of purpose. They believe they are needed by others, and they feel productive socially. People do like to feel needed. That's a big feeling for a lot of people. A sense of belonging was found to promote health, while a lack of this seemed to impair health. And an increased sense of belonging was also associated with decreased levels of anxiety. So social networks, these are groups of people whom one feels connected. And then we have social support, which is the emotional sustenance that comes from friends that provide help when a problem arises. People who are supported emotionally and functionally have found to be healthier than those who are not supported. And I think if we all sit back and think of a time when we dealt with something that was pretty uncomfortable, if someone was there for us, we can attest to the meaning of that. And if someone didn't show up for us, we can also attest to how that feels and probably agree with that statement. So there are two key components that are necessary for a support system to be effective: the client's perception of the support system. So the patient has to recognize that they have a support system, and they have to recognize that those people are there to support them. So some people may have what we consider a support system. If we think that they have family members that they live with, well, it doesn't mean that that person views them as a support system. If they don't, they might live with them. Maybe it's their brother and their sister and their parents, but if they don't support that patient, and if the patient doesn't feel like they're a support, then they're not really a support system. So it's what the patient thinks. And then the responsiveness of the support system. So like I said, do they show up for the patient? Are they really what we would consider a support system? The support provided is what the client wants, not what the supporter believes would be good for the client. So we have to remember this in mental health. It is all the time geared around what the patient wants, because they're the patient, they're the people that need to be supported. They're the ones having the issue. While family and friends may be able to give you insight about a patient, it ultimately is not what they believe is best for the patient. And then the support system must be able to provide direct help or material aid. So we're looking at things like, can they provide transportation? Can they take them to their weekly meeting? Can they really show up for them and pick them up every month and take them to Walgreens to get their prescriptions? Can they bring them to their appointments? That's really providing that direct care. So families might say, oh yes, I'm going to be able to do that, but then they don't do it. So they're not really considered that support system. So when we talk about family support, this is family strengths. So family strengths are love and caring. These are key factors in the recovery of clients with psychiatric illnesses. Healthcare professionals cannot totally replace family members. There's no one like your family. The nurse must encourage family members to continue to support the client even while he or she is in the hospital. And the nurse should help identify family strengths such as love and caring as a resource for the client. Sometimes they just need a little reminding. Just like our physical illnesses, our mental illnesses also have cultural factors that are very important. So culturally competent nursing care means that we are being sensitive to the issues that are going to be related to their culture, their race, their gender, their sexual orientation, their social class, their economic situation, and a variety of other factors. As healthcare providers, we must learn about other cultures and become skilled at providing care to people with cultural backgrounds that are different from ours. So when we're just starting out as nurses, we don't know about every culture that there is and all the backgrounds. I mean, we teach you generalized information that you might retain by the time you actually start working, but you might not, and you're not going to know everything. But we need to understand that we have to be aware and that we have to learn. And when we're given the opportunity, we really have to learn as much as we can and try and retain it so that we can apply it again when we take care of another patient from a similar culture. We know that culture has a big influence on a person's health beliefs and their practices, and it also influences one's concept of disease and illness. And mental health is no different. We need to understand their beliefs about the causes of illness. So some clients might try to counteract the negative forces or spirits because they believe that if a person is suffering with some type of a mental illness, that it's a spirit or they're being punished for some reason. So they will try and use traditional cultural remedies rather than taking a medication or changing his or health practices. So when we talk about patients that are being non-compliant, so if you're a patient just started a new medication and you see him again in 4 weeks and you're reevaluating what went on with the medication. And if he says, I'm not taking the medication, I didn't take it at all. We can't just say, there's no hope for him. He's non-compliant. There's always an issue why they are not compliant. So using this example, they wouldn't, depending on what culture they have, they probably won't even believe that medication will help because they think it's a spiritual thing. And they have to use their traditional remedies. So we need to do a lot of education. These people need a lot of education. And then what causes illness? So there's two types of beliefs about what causes illness: natural and then unnatural, which is personal. So natural is going to be rooted in a belief that natural conditions or forces such as cold, heat, wind, or dampness are going to be responsible for illnesses. Unnatural or personal are going to attribute the cause to the active, purposeful intervention of an outside agent, so a spirit or a supernatural force. Sick clients with these beliefs would not see the relationship between his or her behavior or health practices and the illness. They would counteract the negative forces or spirits using that traditional cultural remedy rather than taking a medication or changing his or her healthcare practices. So these are important things to keep in mind. Other factors in the cultural assessment: communication. Communication can be very difficult if the client and the nurse are not speaking the same language. So we need to make sure that we have a family member there that is able to relate, that we have an app on our phone that we can use through our employer, or if our employer has like a language line, we want to make sure that we are taking advantage of those opportunities and using those supports so that we know that the client is understanding everything that we are trying to tell them. If they don't understand, sometimes they'll just give up and they'll nod their head yes. We don't want that, especially in mental illness. So we also need to be aware that nonverbal communication has a different meaning in different cultures. So we talked about touch. So some cultures welcome it. It's completely fine that you go in, you sit at the end of the bed and you hold your patient's hands. Some people find it very offensive. And it's going to be a barrier between that developing that therapeutic communication between you and the patient. We talked about direct eye contact. Some cultures view it as positive, while others view it as rude, and they will try and avoid making eye contact, which may make you believe that the patient isn't interested in what you have to say and they're not taking their illness seriously, when really that's not the case. So we just need to be aware of those issues. And then physical distance. So standing close to one another might be okay for some patients, or some patients might require 2 to 3 feet of distance. So we just want to be conscious of the cultural differences in space, and we should always allow enough room for our clients to be comfortable, because we want them to be able to open up and talk to us. So social organization. This refers to the structure of The structure and organization of religious beliefs, values, ethnicity, and culture. Some patients will make decisions about healthcare independently on their own, while others may seek the advice of a family member or friends. Sometimes you'll see that a whole group of family members will come in. It'll be the sons, the daughters, the wives, the grandchildren, all of them help the family member make a decision. Sometimes they don't even want to consult their family. They just want to have a friend come in, or they're completely comfortable doing it for themselves. Again, culture is going to have a big effect on which way they go. We strongly value the role of the family in making healthcare decisions. So if we recognize that the patient really needs to have their family members there to make these decisions, then we would want to delay making really important decisions until they're able to meet with their family members, or until those family members can come in and we can kind of educate all of them together so that they can make a good conscious decision regarding treatment. When we talk about time orientation, so some cultures value punctuality and having a precise schedule, other cultures do not. Any kind of organization and time goes right out the window. So they might not understand the importance of adhering to taking medications at a certain time, or following up. And, if we say we need to see you on June 2nd at 9 a.m., they might even skip the appointment because they don't think that it's important. So we as nurses need to be sensitive to the client's time orientation, as with follow-up appointments. So we need to make sure we're really educating them and telling them, it's really important. We just started you on these medications. We need to see if you have any side effects. It's really imperative that you keep this appointment. So just really educating them. And then if they're going to be taking medication at home that's given at a certain time, we want to make sure that we are stressing that in our education. And there's environmental controls. So this is the client's ability to control the surroundings or direct factors in the environment. So if they believe that they have control of their health, they're going to be more likely to seek care if they feel like something is off. If they seek care, they're going to be more apt to change their behavior. If they change their behavior, they're going to follow those treatment recommendations and they are going to get better. If they believe that the illness is a result of nature or some type of a natural cause, obviously they're going to be less likely to seek traditional health care because they don't believe that it's going to help them. And then we always have biological variations. So we see illnesses that are just with a certain ethnicity or culture. So in African Americans, we see that they suffer from sickle cell anemia. And then our Jewish community, they suffer from Tay-Sachs disease. We talked about that in fun. So that should kind of be, you guys should recognize that. So socioeconomic status and social class, we know that that's going to have a part in their ability to get better, seek treatment, be compliant. So we talk about a person's income, their education, and their occupation. So if they don't have money and they're living at poverty levels, they might not be able to afford to get health insurance, to be able to seek treatment. Depending on their education level and their level of understanding, they might not even know that there's programs out there that could help low-income patients get access to free medication and free health care. If they have a job and they're highly educated, then maybe they have an employer that pays for benefits and they know the value of education and taking care of yourself. They've learned. So we need to be aware of that. People living in poverty obviously are at greater risk to their health, such as inadequate housing. So we're going to be dealing with issues of lead paint, gang-related violence, drug trafficking, and substandard schools. And then social class. Social class has less of an influence in the United States than it does in other countries. So we, in the US, there are barriers among the social classes that are loose, and then mobility is very common. So people can get around. People can gain access to better schools. We can gain access to housing if we can't afford it. Access is there for free healthcare if you don't work and you need it for yourself and for your children. And then, lifestyle as they increase their income. In other countries, the social class is always very fixed. So it is going to be a powerful influence on social relationships, and it can determine how people relate to each other, even in the healthcare setting. Knowledge of expected cultural patterns. So the nurse can use what you've learned or what you've in nursing school or what you've learned in experience as a starting point when you are relating with people from different ethnic backgrounds, and then you build from there. And it's always okay to ask, another nurse. This is my first time caring for a patient with a Jewish background. What do I need to know? Can you give me any pointers? Do you have any information? Always, always ask. You can Google things. You can go back to your nursing books. There's wide variations among people from any culture. So just because if you're talking about the Jewish culture, if this percentage of people don't eat red meat with cheese together, doesn't mean that they all do that. Some people. You guys need to have your microphone muted, please. Doesn't mean that everyone does that. So those are just things to keep in mind. There's always going to be variations. And then the nurse must learn about greetings, acceptable communication patterns, and beliefs regarding mental illness, healing, spirituality, and medical treatment so that we can provide the best possible care, because we want to build that great therapeutic network with our patients. So the nurse's role in working with patients from various cultures, where our ultimate goal is to always provide the most culturally competent care. The nurse must find out as much information as possible about the client's beliefs, their values, and their health practices. And it is absolutely okay to ask your patient. So when you meet when you meet your patient, you can introduce yourself. Hi, I'm Trish. I'm going to be your nurse today. Tell me a little bit more about how you would like to be cared for. What's important for you? What are your goals for today? What do you expect from me? What do you want me to do for you? What are your priorities? These are all things that you can say to your patient. At that initial meeting, the nurse should be alert for client preferences for greeting, making eye contact, physical distance. If you're getting too close to a person and you're making eye contact with them, you're going to be able to tell there's going to be that nonverbal communication that patient feels uncomfortable. So just pay attention to those nonverbal cues. Always remember that your patient is the best source of information, unless they're not coherent and they don't know who they are. Then it's going to be your family members. But 9 times out of 10, if they're alert and oriented, they are the best source of information. And I see that a lot, especially with older patients. I see it with when their kids come in. And even though the patients themselves are completely alert and oriented, their family always speaks for them. And it's not something that I ever call the family members out on unless I have to, like especially with pain medicine. I'll come in and I'll say, Mrs. Jones, how's your hip pain? And, I had a daughter say one time, it's 9 out of 10, she needs pain medicine. And I said, well, I have to evaluate that from your mom. I have to hear her say it. And then, the daughter looked at her mom and she was like, she didn't know what to say. And finally she was like, well, it's really not that bad. And she would be like, Mom, you need to have this. So it's okay to include the family sometimes, but sometimes it's not, especially if they're coherent and they can make decisions. You always want to hear what the the patient has to say. General cultural knowledge to help guide the nurse in those initial meetings when you first meet your patient, when they get admitted to the unit, and any decisions about what questions to ask. So we want to ask the patient about their preferences. We want to talk about their healthcare practices, what's important to them. What are their beliefs? If they pray, do they pray every day? What time of the day do they like to do it? So that way you can make sure that you're planning things around their schedule. I mean, obviously when patients come into the hospital and they're sick, some things we just have to do, especially if they're deteriorating and, we don't have a lot of time and we have to implement changes pretty quickly. But for the most part, we do try to meet those needs. So we want to know about those dietary restrictions, those religious and spiritual beliefs. We must gain an understanding of the client's health and their illness beliefs, because that's going to tell us a lot, what we need to educate them about. How do we expect them to handle this? And we're going to ask a lot of questions. We're going to use open and objective approach. ask a lot of open-ended questions. We want to get as much information from them as we can get. And then remember, you might think that you know a lot about a certain culture, but the general knowledge does not replace the patient assessment. That's really important, you guys, to remember that, because there's a lot of variations in culture. So just the knowledge that you have about a certain culture is not the best for each patient. So you always have to do that assessment. So some examples of what some questions you could say are, how do you think your healthcare problem came about? What kinds of remedies have you tried at home? So if your patient tells you, well, I've been stressed out, my mother's been very sick, I've been taking care of my mom, and then I stopped eating, and then I lost my job. That's a lot different than if they say, well, I'm being haunted by a spirit because I did something wrong in my childhood. So that's going to tell you exactly how you're going to have to handle the patient, what kind of education you're going to need, and you're going to be able to understand how he's going to respond back to you. Whoops, too many. All right, so self-awareness issues. So in mental health, just like physical, we always have to be aware of ourselves and our beliefs. So we need to be aware of any kind of factor that's going to influence a client's response to illness, including the individual, interpersonal, and cultural factors. I feel like some patients get embarrassed when they don't manage their health and they come in with some kind of a chronic, uncontrolled issue. But with mental health, I feel like that's even worse. People are embarrassed to say that they're feeling this because some people think it's a sign of weakness. Especially I see this a lot with men. I think that society thinks that men have to be so strong, and I see that they have a hard time sometimes saying, I feel this way or I feel that way. So we really need to be aware of those factors. We need to think about those biologic and hereditary factors that cannot be changed. So maybe a patient is acting a certain way that you don't agree with, but maybe it's not anything that's in their control. They can't help it. And then limited personal experience can also cause anxiety. So just becoming a nurse, you don't have a lot of experience. You're always afraid you're going to say the wrong thing, or you're going to do the wrong thing, or you're going to offend them some way, or you're going to be disrespectful. We are always at risk for developing stereotypical concepts about certain ethnic groups. Or people in general, and we actually may be unaware of them until we encounter a client from that group. So we need to be aware of that. It's a constant challenge, mental health and just regular med-surg nursing, to be aware of a person's feelings and to handle them effectively. But it definitely starts with us. And then points to consider when working with individual responses to illness. So we always want to approach our patients with a genuine, caring attitude. We have to be genuine. We have to make sure that our patient is our priority. We have to genuinely care about them. And we want our client to feel that we're genuinely, that we care about them and we want to help them get better. So smile when you come in the room. Take that time to really be present with your patient. Sit at their bedside. Let them know that you care about them. Ask the client what their preferences are, what their religious preferences are, any healthcare practice needs. Recognize any negative feelings or stereotypes and discuss them with a colleague to dispel any myths or misconceptions. And remember that there is a wide variety of factors that influence the client's complex response to illness. It's not always non-compliance. All right, any questions about that material? Okay, we're going to go to the next one. All right, so psychosocial integrity. So this is our assessment. So just like in our med-surg nursing, assessment is always going to be the first step of the nursing process. So in mental health, it's no different. So it's going to involve you interviewing your patient, collecting your information, organizing it, looking at all the information that you gathered, and then making some type of diagnosis and making some implementations for some interventions. In psychiatric mental health nursing, this process is often referred to as a psychosocial assessment, and it does include a mental status examination. So the purpose of our assessment is to construct a picture of our patient's current emotional state. We want to know, what kind of emotional state are they in? Are they in a good emotional state, or are they having a crisis? What is their mental capacity? Are they capable of making decisions? Are they capable of being in the outside world and making decisions for themselves or others? And then their behavioral function. This psychosocial assessment is the basis for developing a plan of care to meet your patient's needs. And it is going to be that clinical baseline that's used to evaluate effectiveness of treatment or measure a patient's progress. Because if we don't have a baseline, we have nothing to compare it to. We're never going to be able to know if the interventions that we put in place are effective and if our patients are getting any better. So some of the things that factor our assessment, we talk about active patient participation and feedback. So we want to make sure as physicians that we are, not physicians, providers, that we provide a thorough and complete psychosocial assessment. And in order to do that, we have to recognize that it includes participation from the client. So this could be difficult with mental illness, just like it could be with our med-surg patients, depending on how sick they are. They might not always have that active involvement. Well, when the mind is sick, it's going to be the same thing. So with our depressed patients that have extreme depression, they don't have any energy. Or if they're in some type of a psychotic state, they might not have the appropriate attention span to really sit with you and give you the proper information. If they're hearing voices and things like that, you're not going to get the proper participation that you require. So keeping that in mind, the assessment sometimes has to take place over several visits because the patient can't sit there for long periods of time. So you just have to recognize that you kind of have to tailor it to meet their needs. If the client's health status, we want to look at, are they in any pain when we're trying to talk to them? Are they completely exhausted? Are they anxious? I mean, when I get patients that are really sick, that come up from the emergency room and they've been boarding in there for 16 hours, sleeping on a cot, the last thing what they want to do is have me sit at their bedside and ask them questions for an hour. So I defer that till after they have a little bit of a rest. I get them settled. I get the essentials out of the way, like code status, get their fluids set up. And then I say, okay, I'm going to let you rest. I'll be back. And this is what I need to go over. So you need to make sure as the nurse that you're recognizing that and then addressing the needs. So if your patient's in pain, he's not going to want to sit there and have this open, great, conversation with you when he's in pain. He's not going to be focused on what you're saying. He's going to be focused on the pain. So we want to give pain medication ahead of time. If they haven't slept, it's probably not going to work. If they're really anxious, it's not going to work. So we want to be able to give them medications to help with the pain and the anxiety. We want to take into consideration the client's previous experiences and misconceptions about healthcare. So the nurse has to address the client's feelings and perceptions to establish a trusting working relationship before proceeding with the assessment. So the last time I worked, I went to the mental health unit on my floor, which is a small unit. We don't have a big psych unit. We only have 6 beds. But one of the patients I was taking care of was a very young patient, 20 years old, had tried to commit suicide 3 times in a week. He kept taking multivitamins, trying to kill himself. And he was there. He was involuntary there. His mom had him committed, and it went in front of a judge, and the judge says, no, he can't make his decision. So he couldn't leave, but they wanted him to go to Shepherd Pratt. And he didn't want to go back there because they said they had treated him terrible. They drugged him up. They gave him all kinds of medications. They locked him in a dark room. He didn't eat for a couple of days. So this was his misconception about the way he had been treated in a previous facility. So we need to take that into consideration, and we need to listen to them, and we need to hear them out, because if they're ever going to be compliant with care, we want them to be on board with it at least somewhat. I mean, in certain situations, they don't even have the mental capacity to be on board, and then things just happen as they may. But for the most part, we try and get them on board, and we want to be considerate of their, what they feel. And then we have to think about the client's ability to understand. So Thinking about hearing, do they have hearing aids, but they need hearing aids, but they don't have them with them? Are they blind? Do they need Braille? What's their education level? Are they even able to understand? Is it a language barrier? Do you not speak the same language as them? So those are important things because we need to be able to get all that accurate information from them. So we all need to be on the same page. The nurse obviously must provide accommodations for the client who's hearing impaired or vision impaired. If the language between the nurse and the patient is indifferent, then information can be misinterpreted. The nurse's attitude and approach is also going to affect our assessment. So we have to ask these questions in a calm, non-rushed, non-judgmental fashion. So we need to be self-aware. We need to have self-awareness about different mental illnesses. And we can't let our feelings or our stereotypes come through when we're caring for these patients. We can't be rushed. We can't be focused on what's going on with other patients. We need to be present with our patients. And we need to be calm. Some patients that have mental health issues take a variety of medication that delays their speech. Or they've been taking them for so long, it's just that's the side effect that they have now. And so their speech is delayed. They don't always put the right words together. So we don't want to rush them along and make things worse. And we don't want them to think that they're inconveniencing us. Be aware of our own feelings, and then clients can avoid sensitive topics and withhold important information. So if we're dealing with a patient who was, if I was a male patient and I was dealing with a female patient who was sexually abused by an older male at some point in her life, she might not want to discuss all that important information with me. So I have to recognize that. And, sometimes it's better to just bring someone else in if they're not going to discuss those sensitive topics with you. So setting the stage for conducting the interview. So we always want our environment to be conducive to get as much information as possible. So we want the patient to be comfortable. We want them to be in a relaxed environment. We want it to be private because they're talking about things that they might be embarrassed about and they don't want other people to hear. And we want the patient to feel safe, especially if you're dealing with patients that have anxiety and paranoia, or they're having hallucinations, or they're hearing voices. We want them to feel safe. So we want it to be quiet with few distractions, and it allows the client to give you his or her full attention. We also need to be aware of threatening behavior. So we want to provide a private, safe environment for the patient. But as nurses, we also have to keep ourselves safe. So sometimes that means that if this patient has a tendency to have violent behavior, you don't want to be alone in a room with them. You don't want to sit with your back towards the door. You want to keep the door open. Maybe you want to have another nurse come in and sit with you. You always want to keep yourself safe. We do want to get input from family members, friends, and caregivers, but the patient has to give permission. It's just like everything else. There's a HIPAA law. We just can't give information or take information. We can't discuss the patient's information with other people. Patients may be comfortable or uncomfortable with or without family members present, especially in the case of suspected abuse or intimidation. We always want to keep those patients in private and ask those questions only with the client, because it can, if they are being abused by someone or someone's intimidating them, we're not going to get the information that we need. And then we need to obtain information about the perceptions of the client. So how do they perceive things? Doesn't mean that that's really the way they are, but if we're going to make any strides with the patients and we're going to work through problems, it's important for us to understand how they view things. So using a non-judgmental tone and language. So when we speak to the patients, we want to use open-ended questions to initiate the assessment. So, hi, Ryan, what brings you here today? What can we help you with? What's important to you? What do you want to talk about? It's a focused assessment if the patient is capable of organizing their own thoughts. If they have difficulty or if they have difficulty answering those open-ended questions, then you have to kind of ask more direct questions to get the answers that you want. So how well have you been sleeping? Hopefully they'll give you the answer you're looking for. How many meals do you eat a day? Instead of saying, tell me about your your eating habits. That might be very overwhelming to tell someone, where how many meals can you eat a day might be manageable for them to comprehend and to be able to explain to you. So what's included in that assessment? Well, of course, there's always a history. So their age, how old are they now? Their developmental stage. So does that correspond with their age? If they're 42 years old, did they speak and make decisions and engage in conversations like someone that age should? Or are they mentally challenged somehow, and they maybe they're 42, but really have the the cognitive ability of maybe a 6-year-old. Then there's cultural considerations. We want to know about their spiritual beliefs. Then we want to know about their previous history. What have they dealt with in the past? So their medication history, their medical history, their mental health history, surgical history. And then we want to know what their beliefs are about health and illness. We also want to look at their general appearance and their motor behavior. So just like we do in the acute care setting, we do that snapshot picture when we go in the room and we look at them. This is kind of the same thing. So we're looking at their overall behavior. Are they sitting tall in their room? They're nicely dressed, their hair is combed, they've brushed their teeth, their hands and legs are folded, and they're very calm? Or are they very, very unkept? Are they disheveled? Is their hair everywhere? They smell. They haven't had a bath for days. They're rocking back and forth. They're rolling their fingers inside their hand. They're looking all around like they're nervous. So really take a look at that general appearance. Check out that motor behavior. Are they dressed appropriately for the weather? So sometimes patients that have manic issues, they will dress crazy in just like crazy off the wall things. So it might be 102 degrees outside and they're wearing a flannel shirt with ski pants and boots. That's really not appropriate. So that could be a sign of some type of a manic behavior. And then we want
Professor Davis, I'm sorry, can you let Raven in?
Oh, yes, sorry. Thank you.
Thank you.
So then we want to assess the client's speech. So we would look at the quantity of the speech, the quality, and any abnormalities. So are they talking really, really fast like this and you can't make a word, you can't understand what they're saying? Is this how they sound? Do they take too long to answer something? Are they nonstop talking? You can't get a word in edgewise. Or are they just kind of like disconnected from you and they're just giving you the yes, no. They're not giving you any more answers, just the minimal. We look for, and these are important, I want you guys to know these, we want you to look for automaticisms. These are repeated, purposeless behaviors that can indicate that the patient has anxiety, such as when they're sitting and they're drumming their fingers, they might be sitting like this, twisting their locks of hair, or tapping of the foot. We want to look for psychomotor retardation. So this is just a slowed movements in the patients. Overall, all their movements are just slow. Doesn't matter what it is. We talk about waxy flexibility. So this is the maintenance of posture or position over time, even when it's awkward or comfortable. So if your patient is all hunched up in a ball with his knees behind, his head in between his knees, curled up in a ball, and he sits like that for 3 hours, we know that it's uncomfortable, but they keep that posture. And then neoglyphs. This is invented words that have no meaning, only for the client. So you guys need to know what those are. You're going to see them on your exam. So we want to know about our patient's mood. So this is going to refer to the client's pervasive and emotional state. We also want to look at their affect, and you guys need to know this too. So our affect is our expression, our outward expression of our emotional state. So the client can ask the patient, just like we ask our pain, to rate your mood on a scale of 1 to 10. We also want to assess for consistency throughout this assessment. So if you say, Brian, tell me about your mood on a scale of 1 to 10. 1 is you are extremely depressed, and 10 is you are extremely happy. And if he looks at you and says 10, well, that's not consistent with what he's showing us. So we always want to check for that consistency. When we talk about we can have different types of affect. So a blunt affect is where they show little or very slow to respond facial expression. So there is some facial expression. It's just very little or it's very slow to respond. A broad affect is displaying a full range of emotional expressions. A flat affect is showing absolutely no facial expressions. We have an inappropriate affect. So this is displaying a facial expression that is going to be incongruent with the mood or the situation, often silly or giddy, regardless of circumstances. So I will never forget the time where we had to do CPR on a patient. I wasn't a nurse that long, and there was another nurse in there with me who had been a nurse a lot longer than me, and she was doing compressions and laughing the entire time because that's what happened to her when she got nervous. And everybody in the room thought she was just a complete maniac. Like, what's wrong with you? How could you laugh at this? But that was just the way she handled stress, no matter what happened. So maybe she has some kind of mental disability now that we're talking about it. I just think it's just how she handles her anxiety. But it was a little strange to see that this person was dying and she was laughing the whole time. And then we talk about restricted affect. So this is displaying one type of expression, usually serious or somber. And then labile. So the client is going to exhibit unpredictable and rapid mood swings from depressed and angry to euphoria with no apparent stimuli at all. So you guys need to know about those also. You're going to see that on your exam. So we want to know about the thought process. This is going to refer to what the client thinks. How does the client think? And then the content, so what the client actually says. So we want to know whether or not what the client tells us makes sense. If his ideas are going to be related and if they flow logically from one to the next, if he's not staying on topic or the things that he says just don't make sense, they're not, interacted with each other, then that's an issue. The nurse must also determine whether the client seems preoccupied. So is it hard for you to keep their attention? Does it feel like they're kind of like drifting off and they're looking elsewhere and you have to repeat the question a couple times before they respond to you? If they're talking or paying attention to someone or something else. So these next couple things you also need to know as well. So circumstantial thinking. This is a client's, this is when a client eventually answers a question, but only after giving excessive, unnecessary detail. Delusion is in a fixed false belief, not based on reality. We have flight of ideas, which is an excessive amount and rate of speech composed of fragmented or unrelated ideas. And then we have ideas of reference. So this is a client's inaccurate interpretation that general events are personally directed to him and her, such as hearing a speech on the news and believing that the message had a personal meaning. Loose associations, you guys need to know these too. So loose associations are disorganized thinking that jumps from one another with little or no evidence of relation between the thoughts. So it's not going to make sense. The conversation is not going to flow. Tangential thinking is wandering off the topic and never providing the information requested. So they kind of like start talking about what you're asking, but they get completely sidetracked. And then you wind up talking for a long time and the information you asked never even gets to you. Thought blocking is stopping abruptly in the middle of a sentence or a train of thought, sometimes unable to actually continue with the idea. Thought broadcasting is a delusional belief that occurs when people say that they can hear or know what the client is thinking about. Thought insertion is another delusional belief that others are putting ideas or thoughts into the client's head that are not those of the client. So somebody else is able to get into their mind and put thoughts there that they're not capable of thinking. And then thought withdrawal is the delusional belief that others are taking the client's thoughts away and the client is powerless to stop it. And then word salad is just a flow of unconnected words that convey no meaning to the listener. And it is exactly what it is. It's always like pancakes, roof, cell phone, cup, paper, glasses. and they say it in a context like they're asking you a question, but they put all those words together and they don't make any sense at all. So we will encounter some patients that are threatening to commit suicide or hurt others or have in the past. So as the nurse, you are responsible for assessing if the client has suicidal ideations or a lethal plan. So we have to be very direct but respectful with our answers. And we just have to be very direct and say, do you have any thoughts of suicide today? And if they say yes, then you have to say, what thoughts of suicide have you had? And then the patient will tell you. And then you have to say, do you have a plan to carry it out? If they do have a plan, then you have to say, tell me your plan. What are you going to do? And then if they're talking about hurting someone else, then you have to say, what thoughts have you had about hurting whoever it is? Put that person's name in there. Tell me what you want to do to that person. And then, so we always talked about HIPAA and preserving our patients' privacy. This is one aspect where the nurse can't do that. So it's called a duty to warn. And the healthcare provider, as nurses, we are legally obligated to warn the person who is the target of the threats or the plan. And we have to get in touch with the police or the federal government, whoever's involved. You would go to your charge nurse and let them know, and then they would contact the appropriate people. So this is one situation where we must breach the client's confidentiality to protect the threatened person. And you can read more about these suicide assessment questions that we ask. It's listed in box 8.2 on page 132. So we talk about more content in the assessment. So we look at the patient's sensorium and their intellectual processes. So their orientation. Is the patient able to know who they are, where they are, and what time it is? So we usually say alert and oriented times 3, or alert and oriented times 2, or alert and oriented times none, if that's the case. So we want to know about their memory. So we want to do recent memory and remote memory. So what is your social security number? You can ask them about what they had for lunch yesterday. We could ask things about long-term memory. How many kids do you have? What year were you married? Talk about short-term memory. So what did you have to eat yesterday? Which family member came to visit you? Those are short-term. Then we want to know about their ability to concentrate. So we could give them this example. We could say to begin with the number 100 and then count backwards, subtracting 7. I mean, I think I would fail that. I'm not sure that I could do that without a lot of thought, but we want to know their ability to be able to concentrate. And then we want to look at their abstract thinking and their intellectual abilities. So we can ask them to spell things backwards. So you could say, spell the word world backwards. Begin with the number 100 again, subtract 7, and so on. That's called serial sevens. And then we could have them repeat the days of the week backwards. These were all examples in your book. There's more in there. Actually, I just grabbed a few. So if you want to read them, they're in your book. And then we have to be aware of patients that have sensory and perceptual alterations. So hallucinations. So these are false sensory perceptions that do not really exist, but they are extreme. They are real to the patient. And it's very hard to convince them that they're not there because they hear them and they see them. So auditory hallucination is when they hear voices. These are going to be the most common types of hallucinations, the auditory ones. Visual hallucinations are the second most common. And these are when patients see things that don't really exist. So other people, animals talking, inanimate objects that talk, spirits, things like that. Hallucinations can involve the 5 senses and bodily sensations. Initially, clients perceive hallucinations as real experiences, but later in the illness, after a lot of interventions and taking their medication, they may be able to recognize them as hallucinations. We also want to look at their judgment. So what is their ability to interpret one's environment and situation correctly? The client describes recent behavior and activities that reflect a lack of reasonable care for self and others. Risky behaviors So do they pick up strangers in bars and engage in unprotected sexual activity? These are obviously acts that would indicate poor judgment. And then insight. So this is the patient's ability to understand the true nature of their situation. And they have to be able to accept some type of personal responsibility for the situation. This is something that you will not see with all of your patients. They have to have ownership. They have to have some type of accountability. And you certainly need to be able to address whether or not they have that insight. Hold on one second. We want our patients to be able to describe what they think their strengths are and what their weaknesses are. So we don't always want to center everything around negative. You know, everyone has positive attributes. Everyone has negative attributes. So we want to focus on the negative ones because we want to talk about them and we want to fix them. But we also want to talk about their strengths. And ultimately, we want to have more strengths than weaknesses. So an example of poor insight, can you guys hear me? Am I frozen? Can you hear me?
It's broken.
Oh, okay, because it keeps saying
Yeah,
that.
it's frozen.
Okay. Can you hear me now? Yeah.
Yes.
Okay. I just wanted to make sure. I kept saying that it was unstable. So an example that your book gives of poor insight would be the client who expects all of their problems to be solved with little or no personal effort. So and I'm not the reason that I'm acting like that. It's my medication. As soon as my doctor gets the dose right, I'm going to be just fine again. So there's no accountability there. This patient does not think that he is responsible for any of the problems that he has. So it's kind of be hard until he takes that accountability to actually make progress with their treatment. Whoops. Judgment. So this is the, oh, wait a minute, I'm going backwards. What's happening? Okay, self-concept. So this is the way the patient views themselves in terms of personal wealth and dignity. So their body image. So the nurse can ask the client to describe himself, what characteristics he or she likes about themselves, or what they want to change. That's going to tell you a lot about their personal worth and their self-dignity. And then we want to look at roles and relationships. So the nurse assesses the roles the client occupies and the satisfaction in those roles. So do they feel like they have people around that they can depend on or that they can show up for and be a support for? Do they feel like they can fulfill the roles that their family members or their support system expects of them? An inability for people to be sustain satisfying relationships can result from mental health problems and can contribute to a worsening of symptoms. So then there, in your book, there is, it talks about physiologic and self-care concerns. So you guys can read about that. So with physiologic and self-care, we talk about, is the patient prioritizing themselves? So we know that our bodies need a certain amount of sleep. So are we not giving ourselves enough sleep, or are we just depressed and giving ourselves 20 hours of sleep per night? So we need to make sure we're focusing on those physiologic needs and seeing what those deficits are for the patient. And then data analysis. So after we gather all of our assessment data, we finish the psychosocial assessment. We are going to go in and we're going to look at all the information and we're going to analyze it. And then we're going to start to formulate that nursing diagnosis. So this involves, you always want to think about the entire assessment from top to bottom. Just don't focus on little things that you got here or little things that you got here, because there can be such a variance with information that you might lose sight of what the actual priority is. So you want to look at that whole assessment. And it takes time to go over that. You want to look and try and identify any patterns that you see, any themes, and that could make you lead to conclusions about the strengths that the patients have and any weaknesses that would make you look at their needs, which would help you formulate those nursing diagnoses. It is not uncommon for the client's perception of his or her behavior and situation to differ from that of others, especially if they don't have any accountability. They don't recognize that they're doing anything wrong. The nurse must describe and document goals and interventions that others can understand. So remember, anybody that comes behind us, any other nurse or doctor, they need to be able to look at our goals and our interventions and understand them. The description must contain terms that are not no jargon or terms that are unclear to the client, the family, or other providers of care. So we need to just be careful with the medical terminology. And then we also have to refer them to have any psychological tests. So we can do intelligence tests or personality tests. So intelligence tests are going to be designed to evaluate that patient's cognitive abilities and whatever level of intellectual functioning that they may have. And then our personality tests are going to reflect the client's personalities in major areas like self-concept, if they have impulse control, reality testing, and then major defenses. And on page 135, we have some more charts that you guys can look at. And then our diagnoses. So our psychiatric diagnoses, we talked about back in, I guess it was funds or maybe pharmacology, about the DSM. So this DSM is the Diagnostic and Statistical Manual of Mental Health Disorders. So this classifies psychiatric disorders into categories. Each DSM describes each disorder and provides the diagnostic criteria for each disorder. And then usually taxonomy is universally used by psychiatrists and some therapists in the diagnosis of psychiatric illnesses. So it's used throughout, it's universal. So when we talked early in the beginning and we said we're going to do that psychiatric assessment, we're also going to do this mental health exam. So this is going to look at our patient's cognitive abilities. So what this assesses a couple different categories. So it's going to look at the patient's orientation to person, time, place, season, and day of the week. It's going to look at interpretation of proverbs. It's going to have the patient do math calculations. There is some memorization on there for short-term recall. You give the patient 3 words and then you tell them to remember them, and then you ask them a couple minutes later after you've done some other questions. It identifies common objects. There's pictures and the patient has to identify these objects. It also assesses their ability to follow multi-step commands. So take this piece of paper, put it over there on the table, pick up that pen, draw a heart, put a line through it, put the paper here and sit back down. So can they follow those multiple steps? And then the ability to write or copy a simple drawing. So if you look in your book, it'll go over the mental health examination, but with the ability to write or copy a simple drawing, there's a drawing in there that's kind of complex. It's just a series of shapes that interconnect with each other. But patients that have dementia cannot draw this picture. So this is an indicator of dementia in some patients. And then the fewer the tasks that the client can complete accurately, it reflects the greater cognitive deficit in the patient. So because this exam assesses cognitive ability, it is often used to screen for dementia, which I just told you guys about. So, however, cognition may be impaired when clients are depressed or psychotic. So think about that. So you might have to continuously assess them over, maybe once a week or once every 2 weeks, doing this mini mental status exam to see if things are changing. And self-awareness again. So we know how important self-awareness is. When we, the nurse, are trying to obtain accurate and complete information from the client, we want them to have respect for us. We want to have a good relationship with them. We want them to feel comfortable. We don't want them to think that we're judging them or that we're stereotyping them in any way. We want to build a really good nurse-patient therapeutic relationship. We want to be aware of any feelings or biases and values that we have that could interfere with that psychosocial assessment. Self-awareness does not mean that our beliefs are wrong or that our beliefs has to change. It just means that we are being open and accepting of others' beliefs and behaviors, even when the nurse does not agree with them. And I read this all the time about self-awareness, and then I look at what happens in our world, and I'm sure you guys can relate to this. Like, if we all just had more self-awareness, the world would be so much better, you know? Keep our beliefs what we like, but then also understand other people's and be accepting of them. Gather all the information that we need. Judgment is not part of the assessment process. We need to be open. We need to be clear. We need to be direct when we're asking about personal or uncomfortable topics. Examine our own beliefs, gain self-awareness. This is a growth-producing experience. And then do not allow our personal beliefs to interfere with that nurse-patient relationship and the assessment process. And that is it.